Hello, good evening, everyone. So we are back with a video after a certain gap. So this will be the last part of chapter number 19, endocrine changes in pregnancy. And this video will cover the initial part of the chapter. Okay, just a second. Okay, so let's start. So, in the initial part of the chapter, there are certain key points which are written, and we will discuss these key points. So, you may get questions from these key points as well, particularly in your entrance exams. So, let's start. As we all know, that pregnancy triggers significant changes in the endocrine system, and these changes begin with the early production of the human gonadotropin hormone from the trophoblast, which occurs at implantation. There is prioritization of the fetal growth during pregnancy, and this prioritization can lead to hyperinsulinemia, insulin resistance, increased plasma lipids, and enhanced plasma amino acid transport. Maternal weight gain is also an important factor. There is an increased maternal adipose tissue store, which can contribute to a small portion of the overall maternal weight gain. Weight gain is important because it supports the fetal development, the placenta, and the fluid balance in pregnancy. There is also alteration in the medication pharmacokinetics in pregnancy. Pregnancy alters medication handling due to increased glomerular filtration rates, increased blood volume, and there is also potential for hemodynamic destabilization, particularly in individuals and women who have pre existing heart disease. The cardiac demand during pregnancy is increased. This is because of the increased cardiac output and blood volume, which may destabilize women with pre existing heart disease. In those women with pre existing conditions, if they become pregnant, then careful monitoring is very, very crucial. Placenta and fetal sex differences. The placenta has got a sex, and this placental sex matches the fetal sex. The placental responses to environmental exposures vary by sex, as we will see in the video in the later part. Sex differences in developmental origins of adult diseases can emerge. So, sex differences in various diseases which we see in adulthood can emerge right from the time of implantation and embryonic stage. There is also transplacental cell and DNA trafficking. There is universal transplacental bidirectional trafficking of maternal, placental, and fetal cells. Cell free fetal DNA detection in maternal circulation allows for non invasive screening of various genetic diseases. So, now let's start with the placental development. So, as we know, the placenta consists of two types of cells, the syncytotrophoblast and the cytotrophoblast. The placenta produces essential substances which are important for supporting the maternal and the fetal unit. The normal placentation starts as early as the process of fertilization. So this is how the placenta, the human placenta looks like. So this is the placenta. The placenta consists of two types of cells, the cytotrophoblast and the syncytotrophoblast. And this is the interstitium. Interstitial invasion of the placental cells occurs, and this is the myometrium of the uterus. The fertilization rate is only 25 to 30% after unprotected intercourse. In one out of three conceptions, implantation fails or spontaneous abortion occurs. Pre implantation development occurs within the fallopian tube during the first 5 days. What are the implantation stages? The zygote, which is the three-cell stage after fertilization, it develops into a blastocyst by day 5 to day 6. The blastocyst then enters the uterus. The complete implantation occurs 10 days after fertilization. So, fertilization is a process where the ova and the sperm meet and they form a zygote. And this zygote then develops into a blastocyst by day 5 and day 6. The zygote and this blastocyst then enters the uterus, and this blastocyst undergoes implantation after around 10 days of fertilization. The zona pellucida actually disappears after successful implantation. In IVF technology, most of the IVF technology nowadays allows embryos to mature to the blastocyst stage. So earlier in IVF technology, there was transfer of day three embryos in the zygotic stage, but nowadays it has been seen that the success rates are better with day five or day six blastocyst transfer. So nowadays the IVF labs they are advanced to allow the embryos to mature to the blastocyst stage, and even before embryo transfer, there may be a biopsy of the blastocyst, which is known as a trophoectoderm biopsy. This biopsy actually helps detect euploidy, aneuploidy, and genetic disorders. So, with the IVF technology, with this biopsy, if we can detect all these chromosomal abnormalities, then we can even predict whether the blastocyst is transferable or not. Now, what is the progesterone's hormone's role in implantation? Progesterone is the most important hormone during pregnancy. So, early progesterone synthesis is carried out by the corpus luteum. This early progesterone synthesis by the corpus luteum is critical. The human chorionic gonadotropin stimulates the corpus luteum to produce progesterone for the initial 6 to 7 weeks. So after around 6 to 7 weeks, the function of the corpus luteum is taken over by the placenta, which is known as the luteoplacental shift. The luteoplacental shift occurs at 9 to 10 weeks, and then during this time, the placenta takes over the major chunk of progesterone production. What is the window of implantation? The receptive For implantation to occur, the endometrium should be receptive as well as the embryo should be healthy, and there should be a coordination between the endometrium and the embryo that actually facilitates successful implantation. Synchronized estradiol and progesterone exposure actually prepare the endometrium for implantation. Now let's discuss trophoblast differentiation and invasion. Cytotrophoblast and syncytotrophoblast, as we know, these are the two important cells of placenta. They differentiate, and then the cytotrophoblasts invade the endometrium and they form the anchoring villi. And these villi then invade into the endometrium and the uterine tissues. The uterine vessels also convert to high volume, low resistance vessels so that there is adequate blood supply to support the fetal growth. Placental angiogenesis, the trophoblast cells secrete various angiogenic proteins like vascular endothelial growth factor, platelet derived growth factor. The syncytotrophoblasts they form a key interface for the transfer of oxygen, nutrient transport, as well as waste removal. The human placenta is a hemochorial placenta. The fetal blood is separated from the maternal blood by three tissues: the fetal endothelium, the connective tissue, and the trophoblast. And this type of arrangement is important for it is efficient for nutrient and gas exchange. The transport through the placenta. The hormone transfer basically depends upon the placental blood flow, the hormone molecular mass, and the metabolic degradation. The hormones which are smaller than 700 dalton can cross the placenta, and hormones which are bigger than 1200 dalton do not cross the placenta. So trophoblast also has got immune and anchoring functions. The trophoblast protects the fetus from maternal immune rejection through progesterone and HLA-G expression. The trophoblast also anchors the placenta and the fetus to the uterus. There is also hormonal regulation by the placenta. The trophoblastic mass correlates with the human placental lactogen and the beta 1 glycoprotein levels throughout the pregnancy. HCG secretion is responsible for maintaining early pregnancy, while progesterone is vital after the luteoplacental shift. So, to conclude about the placental development, we know that the placenta plays a very crucial role in hormone production, fetal development, immune protection from maternal rejection, and also maternal adaptation. So, understanding placental function is very, very essential for maintaining pregnancy health. So this is a table which shows the various placental products which we have already discussed in our previous videos. So placenta produces certain hypothalamic analogs like GnRH, CRH, urocortin, somatostatin, growth hormone release hormone, ghrelin, thyrotropin releasing hormone, dopamine, neuropeptide Y, and enkephalin. Placenta also produces pituitary analogs like chorionic gonadotropin, placental lactogen, chorionic corticotrophin, beta endorphin, alpha melanocyte stimulating hormone, growth hormone V, that is placental variant growth hormone, and oxytocin. Placenta also produces steroid hormones like estrogens, estriol, estradiol, and estetrol, pregnenolone, and progesterone. And other products which are produced by the placenta are activin, inhibin, follistatin, relaxin, calcitonin, leptin, parathyroid hormone related protein, erythropoietin, renin, interleukin, nitric oxide, transforming growth factor beta, tumor necrosis factor alpha, epidermal growth factor, insulin like growth factor type 1, type 2, insulin like growth factor binding protein 1, colony stimulating factor 1, basic fibroblast growth factor, corticotrophin release hormone binding protein, platelet derived growth factor, vascular endothelial growth factor, endothelin 1, anandamide or endocannabinide, hepatocyte growth factor, and oncomodulin. So there's a whole list of placental products. You don't need to remember so many things, but just remember the basic, the important hormones which are produced by the placenta, which we have already discussed in the previous videos. Now, let us come to NIPT test and microchimerism. So, as we know, there is a transplacental cell trafficking in pregnancy. So, that means there is a two-way exchange of cells between the mother and maternal and the fetal blood. So, this begins at around 6 to 7 weeks of gestation. There is bidirectional trafficking of maternal, placental, and fetal cells. So, this peaks at term and it persists postpartum indefinitely. This non-invasive prenatal testing, which is prenatal testing, that is NIPT test, this has become very popular nowadays, and it is almost nowadays. I see that many of the gynecologists are advising this test to detect, and this NIPT test is nowadays replacing the biochemical test for detection of genetic diseases during pregnancy. So, it is NIPT test is utilizes the principles of placental cell-free DNA in maternal circulation. There is sequencing of the cell-free DNA to look for fetal aneuploidy. It is a highly sensitive and specific test for detection of common aneuploidies like Down syndrome, Turner syndrome, Klinefelter syndrome, and the trisomy 13, 18, Edwards syndrome, which are commonly detected through this NIPT test. The advantages of NIPT is that it can be used in both low risk and high risk populations. It reduces the need for invasive diagnostic procedures like amniocentesis, and it is superior to the traditional serum screening methods. The limitations of NIPT is that it may give false positive and false negative results. There may be confined placental mosaicism, which may render the results inaccurate. Positive results require confirmation through invasive testing. Just 1 second. Yeah, these are the limitations of the NIPT test. So, what is the future of NIPT? It has potential for broader use in diagnosing single gene disorders and also microdeletions and microinsertions. Now, what is microchimerism? Microchimerism means persistent presence of maternal and fetal cells after pregnancy. Fetal cells have been found in the maternal circulation decades after the birth. This bidirectional transfer occurs from the mother to the fetus as well as vice versa. So, what are the health implications of microchimerism? The possible roles are that microchimerism might play a role in autoimmune diseases like type 1 diabetes or autoimmune thyroid disorders. It can also play a role in tissue repair and rejuvenation. It can also help in cancer protection in certain contexts. Microchimerism also has got an influence on adult diseases via fetal origin hypothesis. It also plays a role in the transmission of cells across generations, for example, from grandmother to the grandchild. So, to conclude, NIPT is a very powerful tool with growing uses in fetal assessment for detection of various aneuploidies. Microchimerism represents a whole new frontier, and microchimerism will help in understanding pregnancy's long term impact on both maternal and fetal health. Now, the next section is sex differences in the placenta. So, a substantial body of literature shows that there is physiological differences between men and women. So, impact of these differences is seen in both acute and chronic conditions. So, there is difference in how men and women respond to acute and chronic conditions. And some differences have been known for decades, while others are being newly uncovered. The common sex differences in health that we commonly observe is that the lifespan, women generally live longer than men. Among the chronic conditions, women are at higher risk for autoimmune diseases like systemic lupus erythematosus, thyroid diseases, and poor bone health like osteoporosis. Men, on the other hand, are at higher risk for metabolic diseases, cardiovascular diseases, and psychiatric diseases like schizophrenia. Response to acute insults, women often respond more favorably to trauma, sepsis, and surgery compared to men. Differences can also be biological or due to socio-cultural factors. The gender-related differences can arise from interactions with biological predispositions. This sex differences, sex and age can act as determinants of diseases. So the sex differences start as early as the fetal and the neonatal life. These differences interact with aging to influence the health outcome. The fetal origin hypothesis suggests that early life events shape the adult health risks. So, this is very, very true because we see that the origin of the adult diseases occurs even during the fetal period as well as the neonatal period. And nowadays, we are seeing so many metabolic diseases. So, these metabolic diseases have their origin during the early childhood itself. So these are some of the examples of early life impact. Insults during pregnancy, for example, natural disasters or severe maternal stress, they increase the risk of neurodevelopmental disorders in the offspring. For example, the famous Dutch famine, which was in 1940, in this Dutch famine, the male offsprings of women in their second trimester had higher risks of schizophrenia. So this was a very famous famine in the 1940s, and it was seen that women who were pregnant during that time, so women who were exposed to this famine during the second trimester, the male offsprings were at higher risk for developing schizophrenia in their subsequent lives. The placenta also has got a sex. The placenta derives from the same cell mass as the embryo, so it has got a sex. The placenta shows sex specific responses to stresses and exposures. Female placentas tend to buffer embryos from environmental insults better than the male placenta. So female placenta are usually found to, protect the embryo better than the male placentas. So hormonal influences in utero, testosterone and estradiol levels also differ between male and female fetuses. The testosterone affects cytokine production differently in male versus female placentas. There is also epigenetic modification. Epigenetic modification means the influence of the environment. So, epigenetics also plays a role in how males and females respond differently to exposures. Female placenta express more immune regulating cells, whereas male placentas express genes which are associated with inflammation. Key epigenetic players are DNA methyltransferase and O-linked N-acetylglucosamine transferase. They are important in placental epigenetic regulation. O-linked N-acetylglucosamine transferase, that is OGT levels, they are higher in female placenta, leading to a more buffered placental environment. So, to conclude, sex differences are the norm rather than exception in health and disease. Recognition of these differences is essential for personalized healthcare strategies. Now, coming to the last part of this video, it is maternal adaptations to pregnancy. So, maternal adaptation to pregnancy, we know that pregnancy profoundly alters every maternal organ. The changes start as early as HCG production during implantation. These hormonal changes primarily drive these adaptations. Some changes are also because of anatomical alterations by the enlarging uterus. There is a key impact on all the organ systems. So we will discuss one by one. In the endocrine system, the early impact is with HCG production from the trophoblast. In the circulatory system, there is gradual changes which include increased blood volume and uterine blood flow. The anatomic changes are caused by the enlarging uterus and the increased blood volume. What about weight gain in pregnancy? Weight gain actually depends upon the pre-pregnancy BMI. There is an Institute of Medicine guidelines for weight gain, and this table is also the subsequent table, which we will see is very, very important. The small portion of weight gain is due to maternal adipose tissue stores. For example, 12.5 kg weight gain in normal women. So only out of this, only 3.25 kg is due to adipose tissue. So you may be asked this question: in a 12.5 kg weight gain during pregnancy, what amount is contributed by adipose tissue? So it is only one fourth, which is around 3.25 kg. Now, this table is commonly asked in various entrance exams, so you should know. Remember in the range in kgs. Okay, so if the pre-pregnancy, we have to see the pre-pregnancy BMI. If a woman is underweight, that is the BMI is 18 point less than 18.5. The total weight gain is usually around 12.5 to 18 kgs in pregnancy. Okay, just remember in kgs, no need to remember in lbs. 12.5 to 18 kgs. That is the normal total weight gain during the pregnancy. In a normal BMI woman, that is BMI of 18.5 to 24.9, the total weight gain is 11.5 to 16 kgs. Overweight woman, the BMI 25 to 29.9, the total weight gain is 7 to 11.5 kg. Obese women, the weight gain more than 30 kg per square meter BMI, the overall weight gain is around in the range of 5 to 9 kg. So underweight will have more weight gain, 12.5 to 18. Normal women will have 11.5 to 16. Overweight will have 7 to 11.5, and obese will have around 5 to 9. And what is the rate of weight gain during the second and the third trimester in kg per week? Underweight will have around 0.51 kg per week. Normal women will have around 0.42 kg per week. Overweight will have around 0.28 kgs per week, and obese will have around 0.22 kgs per week. So this table is very, very important. Try to remember this table. You may be asked about the ranges of weight gain and also the weight gain per week during the second and the third trimesters. The cardiovascular changes during pregnancy, the uterine blood flow increases tenfold to around 450 to 650 ml per minute. The blood volume increases by 40 to 45% at term. The plasma volume increases by 50%. The red cell mass increases by 20%, which results in decreased hematocrit. And so this cardiovascular system basically adapts to prevent severe postpartum hemorrhage. So remember, uterine blood flow increased by tenfold, blood volume increased by 40 to 50%, plasma volume increased by 50%, red cell mass increased by 20%, and the hematocrit decreases. The renal system, the renal blood flow also increases by 50%. There is a 50% increase in the creatinine clearance. The glomerular filtration rate peaks in the second trimester. So because of these changes in the renal blood flow, there may be adjustments may be required in the various medication doses, particularly of antibiotics and anti-epileptics. The cardiac output increases by 30 to 50%. This is driven by increased stroke volume and heart rate. The peripheral vascular resistance is reduced by 20%. Pulmonary changes, the tidal volume increases by 30%. Diaphragmatic elevation reduces the expiratory reserve by 40%. What are the metabolic adaptations? Insulin resistance, there is insulin resistance, as we have already discussed in the previous videos, which is driven by various hormones, particularly the human placental lactogen. Insulin resistance ensures glucose supply for the fetus. There is increased lipolysis, causing maternal energy shift to fats, increased cholesterol during pregnancy for steroid hormone production. And hormones such as human placental lactogen, placental growth hormone, they are primarily responsible for regulating the glucose and the lipid metabolism. The gastrointestinal changes, the gastric motility is reduced, causing nausea, vomiting, and constipation. The esophageal sphincter tone is also reduced, causing increased reflux. The gallbladder, there is a slower emptying, increasing the risk of gallstones. So, to conclude, understanding pregnancy adaptations is crucial for proper care. Many physiological changes that seem abnormal are normal during pregnancy. Medication adjustments and management strategies must consider these changes. So, thank you very much. With this, we have concluded this chapter, and we will soon come with other videos covering the other chapters of Williams textbook. Thank you very much.